Hello, it's Bill, the Knee Pain Guru, and welcome to the Comella Foundation's next edition of Ask Dr. Beck. And welcome, Dr. Beck.
Thank you, Bill. Good morning, everyone.
So how have things been going this week? You had your it was the dental class.
Dental course, yes.
Yeah,
yes.
how'd that go?
I think it went really well. Blew some people's minds. Got people thinking about cases that they had and ways they could help them differently. So, yeah, I think it was definitely a plus.
And these were dentists that you were working with?
Dentists and oromyofunctional therapists.
Nice. And can you give probably like maybe the top one or two that were the biggest mind blowers for your students?
Oh, at the end of the course, we had a patient that was in a dental appliance and her dentist was in the course. So both of them were there. And we got to give feedback from the body on how to adjust the dental appliance.
Ooh.
And it was, for the dentist, just mind-blowing.
So it was like in-time feedback as to what the body was saying, how the appliance needed to be adjusted?
Correct.
That's pretty cool.
It was really great. Yeah.
Neat. Anything else from the class that sticks out for you?
Lots of idea moments. I mean, people would kind of stop me and go, wait a minute, I got a patient that does this. You're telling me I can do this and help the patient? Yeah, that's what I'm telling you. So it was nice.
And this, can you be a little bit more?
Oh, there were multiple thises, but it was, I'd go over a principle about what part of the body works with the teeth. Mm-hmm. And then the person would say, wait a minute, that patient has these symptoms. You mean these symptoms correlate with this thing you're describing? Yes, they correlate with the thing you're describing. And you mean I can do this to help them? Yes.
So it would be like a working with another part of the body to help what's going on in the teeth? Or
so that's one way of doing it. Okay. Most of the time when you find the thing that's going on in the body, it's due to the teeth. And working from the body to help the teeth is not as efficient as working from the teeth to help the body.
So the dentist or the
oromyofunctional
therapist can work with the mouth that will
affect the body. Yes. Oh, yes.
Oh, wow.
Yes. And it could be something as simple as low back pain, for example.
Okay.
Low back pain can come from a bite. So when your teeth come together, they call it occlusion. Okay. It can come from an occlusion that doesn't work correctly. And then the dentist, the body worker, the oromyofunctional therapist can correct what's going on with the teeth. And in real time, the back pain goes away.
Whoa. That's pretty cool.
It's neat.
That would be a game changer. Now, you said it can affect, like the lower back can affect the inclusion in the teeth, but not nearly as effective as going from.
So you can, if you don't change the bite, you can treat the low back, and then when you chew on something, the low back pain comes back. So you didn't treat the source of the pain.
Got it. Okay. Now, is that always the case when you treat the source, the issue doesn't come back?
From a physics perspective, the answer would be yes. If we look at if there's trauma, and trauma is a big umbrella word, but that can mean anything from getting bad news to falling down a mountain.
Right.
Trauma could be getting out of bed and stepping on a kid's toy, right? It's a bad way to start your day. But that little trauma can then cause bigger issues in the body. And then from a physics perspective, that energy that comes into the body from the trauma gets stored.
Mm-hmm.
because it has to follow the laws of thermodynamics.
Mm-hmm.
And until that energy is released, it's
Mm-hmm.
always going to be there, always causing you problems.
Uh-huh.
So when you release the energy, the problem from the trauma at the source, from a physics perspective, it goes away.
Okay. But in an experience of like a PTSD where you have would it be outside of the context of trauma?
Nope.
That
PTSD is still trauma.
PTSD still trauma, then could you give an example of an issue in the body that would return that's outside of
No.
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 Okay.
I mean, at least the way that I've been taught and what I've seen in my clinical experience is
Mm-hmm.
that when you remove the source, the doesn't come back.
Okay.
The hard part is really knowing that you've got the source.
Got it. Okay.
And an analogy that I give would be if you have a car and something's wrong with your car, when you diagnose it correctly and you change the part or parts that are causing you problems, we all assume the car is going to run normally again.
Right.
And if it doesn't run normally, you didn't find the problem and fix the problem. The body is very, very similar.
Got it. Okay. Okay. Cool. I always think when I talk to you different, like.
Yep.
Okay. Let's see. We are full on into the Ask Dr. Beck. Let me get that banner up here. Where did it go? Ask Dr. Beck. So if anybody does have questions, they are able to go to the link below. This will also be in the description of this video to submit questions to us directly. That was set up last week, and we will be working on getting it in a prominent area of the Comella Foundation website for people to submit questions directly. But I was talking to someone that they have issues going on with their son and daughter as far as pain goes. This was an interesting question.
Okay.
How does someone ask a question? And I never thought about this because you're coming at it from such a different perspective. And they're not going to a conventional This isn't conventional doctor approach.
Correct.
How would someone ask a question? How would they go to the Ask Dr. Beck link and ask a question where they can get the most information from what you would have to provide?
Yeah, I have to give you a layered answer. So there's pieces to this that to me are all important.
Okay.
In your mind, you're going to have a question. It doesn't matter what the question is. You're going to ask the question. So that's layer number one.
Mm-hmm.
How you ask the question, what words you use and don't use, the phraseology that comes out with the question is layer number two. And that actually tells me more than the actual question you're asking. Then the tone of everything we'll call layer number three, which also tells me information. So that's it's interesting when I hear it to myself, I'm thinking, well, that's kind of intentionally vague. But the real answer to the question is describe what it is you'd like to know about in whatever words you can. And I'll take that and run with it and try to give you an answer that I hope covers everything. So if it was, if it's about pain somewhere, you two children and each of them have pain, it's different. Child number one, here's what I see. Here's what the child tells me. Child number two, here's what I see. Here's what the child tells me. Then things that help us as physicians to narrow down our diagnosis and make it quicker is what time of day does it occur? Is it all day long? Is it just part of the day? Do the symptoms vary? Are they worse in the morning, better in the evening, or something different? Is there a place where you could place a finger on top of where the pain is? And if that's the case, then someone could send in a picture, for example. This is where I'm experiencing the symptoms. Are there things that you do that make it better? And are there things that you do that might make it worse? So someone might come in and say, I have back pain. You know, when I'm sitting, my back pain is not there. It only occurs when I'm standing. And if I'm walking, it goes halfway away. All of those give me indications as to what very likely is going on underneath, and allows me at least to get to a place to start, in this case, to talk about it, in my office, to start and palpate and find out what's going on.
Got it. Okay. That was because I know it was a friend of mine that had son was having issues with it seemed to be the muscles in the eyes. The eyes were going different directions.
Yes.
And the conventional doctor they were going to was immediately suggesting surgery in order.
Correct. That's the way that they treat it.
Right. So it was, how do I do that from a different perspective? How is it, can it be corrected without surgery? I think that was the initial question.
Yes. And the answer is yes.
And okay. And then the next piece was, well, how do you begin going about doing that? Is that exercises for the eyes? Is that more of a tension pattern that tension patterns are pulling the muscles of the eyes out that are not allowing the eyes to look?
Yes. So the first thing that I would want is like a video showing what's going on, so that I know which way the eyes are going. Okay. And I literally don't need any information in the video other than a shot of the eyes. I don't need the mouth. I don't need anything else, just to see what's going on with the eyes. And then make sure that we verify left is left and right is right, so that the video wasn't flipped backwards.
Yeah, mirrored, like the video is mirrored or something.
Exactly. So after that, once we have a movement in the eye, there are 6 muscles that move the eyeball. Okay. They're thin and relatively wide. There's one of them that goes through what effectively is a pulley. It's a little thinner. And between those 6 muscles, we can move the eye up and down, left and right, and rotate it. Okay, so what the eye is doing will tell me what muscles are working correctly and what muscles may not be working correctly. Then those muscles sit in a housing. It's called the bony orbit. So you've got the globe, which is the round eyeball, and the muscles, and a little bit of fat, and they sit in the bony part of the head. If the bony part of the head has shifted, then the muscles can't move the eye because there's pressure on them.
Are we back?
We're back.
Okay, good. Let's see.
Did you get my answer?
I heard 6 muscles that move the eye.
That's where you stopped. Okay, go. No problem. I'll pick up from there. So we have 6 muscles that move the eye. The eye can move up and down, left and right, and it can rotate just a little bit. The muscles and the globe, which is the eyeball itself, it's the round thing, sit within a little bit of fat in a bony cavity, which is called the orbit. And so the bones, there's 7 bones that make up the orbit. Those bones can move just a little bit.
Mhm.
And if one of them moves, even the tiniest bit, and that can be from a slip or a fall, it can be from a dental procedure. If it moves, it can put pressure on the muscle. The muscle then can't do what it's supposed to effectively.
Mhm.
And so you wind up with an eye that looks lazy.
Mhm.
The muscle tries to move, it doesn't have enough room to move, so it has to stop. And that can be treated osteopathically.
Mhm.
And in many cases, if that pressure is what was causing the muscle not to be able to move,
Mhm.
you get the symptoms to go away.
Mhm.
So it didn't require surgery. It is, at least in my clinical experience, rare to find someone who is from birth has a condition where one eye muscle is shorter or longer than.
Okay. Charlie, are you able to hear me? Hey, Charlie, I think you're back. Charlie?
Yep, I'm here.
Okay. We're both gone? No, I think
Well, we were.
we were. Okay. So you were saying there is rarely from birth.
Yeah, it's rare that you're going to be born with one eye muscle, for example, that's too short or too long.
Got it. So it's not an anatomical thing as much as a tension thing that is created. Am I
Yeah, it's
right?
yes. Adverse tension can cause this to happen.
Okay. So the first thing from your approach would be to look at the orbital bones to see
Yes.
if
Yes.
they're
And then
balanced.
after that, look at the eye itself
Look at the
and
eye.
see if there's something that you can help a muscle do that it can't do on its own.
Got it. Okay, one of those six muscles, and we can actually get kind of fancy here. Hold on a second. I can share my screen and let's see. And I think we have an orbital bone right here.
Yep.
Here we go. Wait a minute. I'll make this a little larger. So this would be the right eye,
Correct.
and we're looking at these.
Yep. And then if you look inside as well, there are bones on the inside.
And are you accessing these bones from the outside,
Yes.
from the tensegrity structure, or
Many times it's just direct.
direct
The sutures, for example, on the outside of the eye,
right
you
here?
can put your fingers on. The
Okay.
sutures on the inside of the eye, for the most part, you can put your fingers on at one of those bones from the outside and through what amounts to physics vectors, get the bones to change at the orbit.
Oh, interesting. That's pretty cool. Now I'm also thinking this would address. Let me stop this. Where did I go? Stop this. Stop sharing. Okay. For people that are building pressure in their eyes from glaucoma and things like that.
Yep. There are ways to assist glaucoma.
Mm-hmm. Got it. Cool. Well, I'm sure I'll pass this along to my friend, but it also helps like how I ask the question.
Yep.
My friend is having this situation with his son, and there's this thing going on, and what can be done, or how can we begin to approach it, which would go into those 3 layers of the question that I had, how to ask the question, and the tone of the question, what you had suggested before, that we can begin to get a door or a foot in the door, so to speak, about the conversation to be had other than having a surgery.
Yes.
Cool. Anything else popping out in your head around eyeballs, orbital bones?
Well, there's a whole nother course on that. So
Cool. And this, once again, we also have your list of courses up on the Ask Dr. Beck
Great.
link as well, for those that are watching that are interested in learning from you. They can certainly access that. Okay, we have a question that came in through the website from Gavin. I don't necessarily, it might not be a question. Let me read this through. This was regarding the simplest exercise for lower back pain. Once again, this is a psoas release from an indirect approach, feet up on the couch.
Yes.
And lay there. Gavin writes, I can't thank you enough. Your method most definitely works. I recently injured myself exercising at home and adamantly searched for a way to treat my lower back pain until I came across your post. During the 5-minute stretch, I definitely felt some moderate pain in the affected area, but standing up afterwards, nothing. No pain whatsoever. It felt a little good to be true at first. It felt a little good.
Too good to be true.
Oh, too good to be true at first. So I continued the process 2 more times to solidify my results. After weeks of pain and only doing this 3 times, I now feel better than ever. After attempting multiple different stretching methods, I'm relieved to know that there's an easy one out there that works. Thanks again. So cool.
That's great.
Some good results.
Yep.
Question for you. Not to put you on the spot, but kind of. We did an interview with you on the Pain Education podcast. I think it was the beginning of the year, and there was a back pain thing that you were going to put together for us.
Yep.
Any status on that?
I think the presentation about anatomy is done.
Okay, cool.
Trying to then figure that out, like, from my side, it's pretty technical about how to move the body. Mm-hmm. I do it with my hands on the body so that I can feel when it's exactly right.
Okay.
Trying to then teach you how to do the thing that I do without my level of education, I'm still trying to wrap my head around.
Okay.
The treatment is insanely easy. Literally, you bend over, take a breath, sit back up. Mm-hmm. But you've got to have your body positioned at exactly the right way for it to treat the structure that is giving you problems. Otherwise, you're treating a different structure.
Interesting.
And I'm trying to wrap my head around how to make that teachable online.
Okay. Cool.
So, yes, we're making progress. Okay. I have not had the aha moment yet of this is how to do it. And my mind goes to, I might need a Hollywood green screen and some performer with the leotard on and it's in the black room and the little ball shows up and they bend, and I'm trying to wrap my head around how to get it to where it can be consistent for you as the user.
Yeah. That way to convey a felt sense in words.
Words and in video, theoretically.
Sure. Yeah, you're definitely doing next level stuff. So, and it is insanely simple. Like everything that Gavin was talking about in his comment was, he didn't do anything terribly complicated. He threw his legs up on the couch, yet it has
your body in a position where it's happy.
Right. And I think that's the biggest challenge with the understanding that it doesn't have to hurt to heal. The body is hardwired or geared or designed to let go of tension if given the conditions to do so.
Right.
So, that is all that came in from last week. I'm not. Let's see. We got the Ask Dr. Beck up. That's all up and running. We'll get that on a navigation bar this week. We're also have it set up to do the pain relief portal, which is we're doing the remote muscle testing. So we're having someone write in through an email. A person is muscle testing exactly which person I've interviewed on the Pain Education podcast, and they will be sent a link so they can have a consultation with that person. So that is set up, and then we're interviewing new people on the Pain Education podcast. So that is all kind of zipping right along. It's kind of exciting. I'm learning some new stuff. Oh, I'll ask you about this. I had a person that spoke about advanced biostructural correction. And it was an interesting angle that they had spoke about addressing the spine, parts of the spine that get shifted forward. And they were looking at it primarily from a chiropractic standpoint, that chiropractors adjust from the back to the front, but not so much from the front to the back. So you have vertebrae that would slide forward towards the center of the body that have issues. Can you speak on that a little bit? Or
so yes, and I'm gonna have to parse what you said into two different categories.
Okay.
So we can have mechanical forces that act to push a vertebra forward.
Mm-hmm.
And that motion is small. We have actual movement of a vertebra going forward. Mm-hmm. That motion is bigger and found on an X-ray. And by definition, because of the way things are engineered in the body, a vertebra moving forward in relationship to its neighbor that's findable on an X-ray also goes along with a fracture of that vertebra.
So if a vertebrae is shifted forward, there is also a corresponding fracture?
There is also a corresponding fracture. So what you're describing is called a spondylolisthesis.
Okay.
Now, the vertebra have a body in the front. Let me see if I can do this. We'll call this, there we go. That's the body.
Okay.
Inside the body is, or above the body, above and below, is the disc. Okay. So that's what people talk about when you herniate something. It's like a jelly donut, the jelly comes out.
Right.
Okay. Behind the body, there's a hole. Okay. And it sits in behind. And then where my fingers are sits the lamina, and basically there's a piece from one vertebra and a piece from another vertebra, and they allow the vertebra to move by these pieces sliding. Okay. And I'm going to try not to make the anatomy too hard, but I can separate them this way a very, very tiny bit when I twist, but they won't allow the vertebra to move past its neighbor from above or neighbor from below.
Okay.
The only way it happens is if you get a fracture and this is out of the way, can the vertebra move forward?
Okay.
Okay. If you look up Scotty dog fracture, that's the easiest way for people to remember the name.
Okay.
When you take an X-ray that goes diagonally across the body, you'll literally
I think we're back now.
Yep.
Okay. Scotty dog fracture. That's as far as I got.
Yeah. When you take an X-ray going diagonally through the body,
Mm-hmm.
What you'll see literally looks like a little Scotty dog with a collar on it.
Okay. We're back. Scotty dog fried. Looks like a Scotty dog. Diagonal X-ray through the body. Looks like with a fracture. It looks like a Scotty dog.
With a collar on it. The collar is the fracture.
With a collar. Got it.
And so, okay, now if we go back. So again, I've separated them into two things.
Mm-hmm.
When you have a spondylolisthesis, getting it to come back is relatively easy in the overall scheme of things, because there's no more bone holding it. Getting it to stay sometimes requires surgery.
Oh, okay.
Because you've got to literally give the bone something where it can't move. So you put a piece of metal in. Sometimes you can do it with injections like prolotherapy. Mm-hmm. And sometimes, and to me, this is the miracle part, you get it to go back to where it's supposed to be. And the body says, oh, that's what I was looking for. And it never gives the person a problem again.
Mm-hmm.
Okay. Now, those, I would say, those are big because at some point there has been a fracture that allows the spondylolisthesis to occur.
Got it.
If we move to the second and easier part, which is there's simply a forward force that hasn't been addressed. Okay. The way that we were taught is if you push from the back to the front.
Okay.
If there is a forward force, it is very hard to correct the forward force. You're correcting backward forces. And I would agree. If you turn the patient over so that they're laying on their back and you know what you are doing, you can use high velocity to correct forward forces.
Okay.
Okay. Because what you're doing is you're pushing from the front to the back.
Right.
So you can correct forward forces.
Huh.
Now, there are many other ways to do it. You can use counterstrain, so you can position the body in its ease and wait for it to respond. You can use other indirect techniques like functional approach, where you unwind the body. And so there are a number of ways to approach these anterior forces and get them to respond. Okay. Now, if the person is asking about anterior forces, well, then you have to look at all the forces, because there are forces that go anterior posterior. There are forces that rotate left and right. There are forces that side bend left and right. And then there are forces that translate. So literally something that moves straight across one way or the other, left and right. And all of those forces can be present in any tissue. Our job is to find the forces and then do what we're trained to do and neutralize them so that they don't exist when we're done.
Got it. Okay. A little bit more in depth than initially. No, that's good.
Yeah.
That's good. And I think it's helpful for those that are watching to understand that there's so many options. There's so many ways to address it's more complex than just say, well, if I cut this out or if I strengthen this muscle, that it all goes away. It's way, way more in-depth, more complicated than that. And I think it opens up possibilities when people think there's only drug, shot, surgery, physical therapy as the only option. Well, okay. Well, I'm stuck with this.
Right. Right.
So, okay. Well, I think we're done for today.
All right. Thank you, my friend. Been a pleasure as always.
Thank you so much. Appreciate you very much. We're going to have more of this stuff tightened up on the website this week, and looking forward to getting more questions, digging into some cool topics.
Yep. Me as well.
Awesome. Well, thank you, brother.
All right. Take care of yourself.
Okay. Bye-bye.